There's a specific, really frustrating irony that comes with managing a heart condition.
Hmm.
I'm thinking of the patient who goes through the whole ringer, the scary diagnosis, the palpitations, you know, the late-night ER visits, and then finally they go through a major procedure catheter ablation to fix their heart rhythm.
Which is a huge deal. I mean, it's invasive, it's high-tech, and the goal is a cure.
Exactly. And by all accounts, it works. The heart is beating normally. You feel like yourself
Yeah.
again. You're ready to celebrate. But then you go to the pharmacy and you realize your relationship with the condition, it's not actually over.
Right.
You're still prescribed these powerful, heavy-duty blood thinners indefinitely.
It's the belt and suspenders approach. We fix the pants, but we're terrified they might fall down anyway.
Right. And it leaves the patient just wondering, if the surgery fixed the problem, why am I still taking this medication? Is this actually keeping me safe, or is it just like medical inertia?
That is the core tension we're exploring today. It's a classic medical dilemma. You've theoretically fixed the mechanical problem, but you're still treating the patient as if the risk is sky high.
So we're doing a deep dive into a really significant piece of research that tackles this exact question. We're looking at an article from the New England Journal of Medicine, published just recently on January 22, 2026.
The title is a bit dense. Antithrombotic therapy after successful catheter ablation for atrial fibrillation.
It is a mouthful, but the mission here is incredibly cool. We're analyzing a clinical trial that pits a potent, modern anticoagulant against, of all things, humble aspirin,
It's a David versus Goliath setup, chemically speaking.
to see if patients who have had successful heart surgery can safely downgrade their meds.
Precisely. And to understand why this is such a big deal and why, the medical community has been holding its breath for this, we have to set the stage a little bit. We're talking about atrial fibrillation, or AFib.
The irregular heartbeat.
Correct. But irregular feels a bit mild. In AFib, the upper chambers of the heart, the atria, they stop beating effectively. Instead of a strong squeeze, they just start quivering. It's like a bag of worms.
Yeah, that's a pretty intense image.
It is, but it explains the risk. When the heart quivers, it doesn't pump blood out efficiently, so that lets blood pool in the corners of the heart.
And pooled blood.
And pooled blood likes to clot.
And if a clot forms there.
It's a loaded gun. If that clot breaks free, it travels straight up the carotid arteries to the brain. And that causes a stroke. And not just any stroke. AFib strokes tend to be large and devastating.
So the standard treatment has two pillars. One is to fix the rhythm, which is often through that catheter ablation.
Right. That's the plumbing fix. A cardiologist threads a catheter into the heart and uses heat or cold to basically burn or freeze the tissue, causing the electrical misfire.
They create a firewall.
Firewall, exactly, against the bad signals.
And the second pillar is the medication, the oral anticoagulants, blood thinners.
Yes. And historically, even if that ablation is a total success, meaning the patient is in a normal rhythm, doctors have been very hesitant to take patients off them.
Why? I mean, if the quivering stops, shouldn't the clot risk just disappear?
You'd think so, but medicine is conservative. The fear is that AFib might return silently, maybe while you're sleeping, or that the atrium itself, even in normal rhythm, is still sort of stunned or scarred enough to form clots.
Oh, cool.
So the default has always been, keep the patient on the aggressive drugs, just in case.
The unknown variable here, and frankly, I was surprised that this was still an unknown until this study came out, is whether a successful procedure actually eliminates the need for that aggressive long-term therapy.
It is surprising. We've been doing ablations for decades, but we've been kind of flying blind on the post-op medication strategy. We've prioritized life-saving prevention without really quantifying if the threat was still there. This study aims to close that gap.
So let's get into the nitty-gritty of this study. Who are we actually looking at here? Because, heart patient can mean a lot of things.
It can. The cohort for this study was 12,284 patients. And to get in, they had to meet a very specific criteria. They had to have undergone a successful catheter ablation at least 1 year before.
Okay, so they're a year out and they're doing well.
They're doing well rhythm-wise, but, and this is crucial, they weren't zero-risk patients. The researchers used something called the CHA2DS2 VASCA score.
Bless you, I always stumble over that
You
one.
know, it's alphabet soup. But it's the standard scale for measuring stroke risk. It goes from 0 to 9. Higher score, higher risk.
Got it.
To get into the study, you had to have a score of 1 or more. Or if you were a woman or had vascular disease risk factors, a score of 2 or more.
Can we break that down just a little? What goes into that score?
Sure. The letters just stand for risk factors. C is for congestive heart failure. H, hypertension. A is for age, being over 65 or 75 bumps you up. D for diabetes. S for a history of stroke. V, vascular disease.
So just to be clear for everyone listening, these are not 20-year-old marathon runners who had a one-time issue.
Not at all.
These are people with some underlying baggage.
Exactly. They have risk factors, high blood pressure, age, diabetes, things that contribute to that score. So the question isn't, do perfectly healthy people need blood thinners? It's, do people with some risk but a fixed heart rhythm need the heavy stuff?
Got it. Okay, so we have our 1,284 patients. How did they set up the battle?
It was an international open-label randomized trial. They split the group right down the middle. Team A got rivaroxaban.
That's a heavy hitter.
Yes. Rivaroxaban is what we call a DOAC, a direct oral anticoagulant. Specifically, it's a factor ZA inhibitor.
Okay, in plain English.
It intervenes deep in the blood's clotting cascade. It's like a sniper that takes out a crucial enzyme needed to form a clot. It's very precise and very potent. They took 15 milligrams a day.
And Team B?
Team B was assigned aspirin, anywhere from 70 to 120 milligrams daily.
Aspirin, the stuff I take for a headache. It seems almost unfair to put it up against a specialized drug like rivaroxaban.
It does feel unbalanced, doesn't it? Aspirin works on platelets. It makes them a little less sticky. But generally, in the world of high-risk AFib, we consider aspirin to be, well, insufficient.
Right. If someone has active AFib, you wouldn't just give them aspirin, would you?
Not anymore. Guidelines shifted away from that years ago because the stroke risk is just too high. So pitting aspirin against rivaroxaban here is a bold move. They're testing if the insufficient option is actually enough when the heart rhythm is fixed.
Now, here's where it gets really interesting for me. Usually in these studies, they give people the drugs and then just wait.
Yeah, they wait.
See if anyone has a stroke or a heart attack. It feels very passive. But these researchers did something different.
They did. They got proactive.
They turned into detectives. They didn't just wait for a catastrophic event. They performed MRIs of the head right after enrollment and then again at the 3-year mark.
And that is a critical detail.
Yeah.
By doing those MRIs, they weren't just looking for clinical strokes, the kind where you lose function on one side or can't speak. They were looking for silent damage.
Silent damage. That sounds ominous.
It is, but it's so important. They were looking for what they called covert embolic strokes.
Okay, define that for us. What makes a stroke covert?
In the context of the source, they defined it as finding one or more new infarcts. So dead tissue from a blockage measuring at least 15 millimeters on the MRI.
15 millimeters. Let's visualize that. That's about the size of a kidney bean? Maybe a small grape.
Exactly. In the brain, a 15-millimeter lesion is not microscopic. It's substantial.
Yeah.
But the brain is redundant in many ways. If that happens in a silent area, a part of the brain not responsible for speech or motor control, the patient might not even notice it.
But the damage is there.
The damage is absolutely there. And we know that accumulating these silent strokes is linked to cognitive decline and dementia later in life.
Wow.
So by including this in the primary outcome, the researchers set a very high bar for success. They weren't just asking, did you survive? They were asking, is your brain effectively pristine?
That's fascinating. It really turns the study into a hunt for evidence, not just a body count.
Yeah.
So the primary outcome, the way they decided who won, was a composite.
Right. To count as a failure for the drug, a patient had to experience one of three things: a full-blown clinical stroke, a systemic embolism, that's a clot traveling somewhere else in the body, or this new covert embolic stroke they found on the MRI.
Okay. The stage is set. We have Team rivaroxaban and Team aspirin. They're followed for 3 years. High-tech surveillance is in place. So what happened? Did the expensive, strong drug just wipe the floor with aspirin?
This is where the data gets really interesting. Let's look at the raw numbers first. In the rivaroxaban group, which had 641 patients, there were 5 events.
5 events. Out of more than 600 people, that sounds incredibly low.
It is very low. That's about 0.31 events per 100 patient years.
Right.
Basically, almost nothing happened. Now look at the aspirin group. 643 patients.
Okay.
They had 9 events.
9. Okay, so 5 versus 9. Just looking at that, my brain immediately goes, well, 5 is almost half of 9. Rivaroxaban worked twice as well.
And if we were betting on a football game, you'd be right. But in science, when you're dealing with such small numbers, you have to ask, was that difference due to the drug or was it just random chance?
The luck of the draw.
Exactly. When they ran the statistics, the relative risk was 0.56. That looks good on paper. It suggests a 44% reduction. But, and this is the big but, the p-value was 0.28.
Translate that for us non-statisticians. A p-value of 0.28. Is that good or bad?
In the world of clinical trials, that's considered not significant. Usually, we're looking for a p-value of less than 0.05 to say, yes, this result is real and not just noise. A 0.28 means there's a pretty decent chance, almost 30%, that the difference between 5 and 9 was just a coincidence.
Wow. So statistically speaking, it was a tie.
Statistically speaking, yes. The absolute risk difference was tiny, negative zero point 0.6 percentage points. The conclusion from the data is that despite rivaroxaban being a stronger drug, it did not result in a significantly lower incidence of these bad outcomes compared to aspirin in this specific group.
That is wild. You take the heavy-duty drug, the sniper rifle, and you basically get the same protection against a stroke as the aspirin group.
In this specific group of patients, yes. Remember, these are people with successful ablations.
Right. But wait, we talked about the detective work, the MRIs. You mentioned the 15-millimeter cutoff. Did they find anything smaller? Like maybe the aspirin group had a ton of tiny little microstrokes that didn't meet that criteria. Is the sniper rifle better at stopping the small bullets?
That is a great question, and the researchers looked at exactly that. They analyzed new cerebral infarcts measuring less than 15 millimeter.
The
microview. And here's what they found. In the rivaroxaban group, these microevents occurred in 22 patients. That's about 3.9%.
Okay. In the aspirin group?
26 patients, so 4.4%.
22 versus 26.
Again, almost identical. The relative risk was 0.89. The confidence intervals overlap significantly. So even when you zoom in with a microscope, figuratively speaking, the potent drug didn't stop these microevents any better than aspirin did.
It really just challenges that assumption that more drug equals more protection.
It does. But we've only talked about one side of the coin so far. We've talked about efficacy, how what if the drug prevents clots. But anytime you take a blood thinner, you have to talk about the price you pay. And I don't mean money.
You mean safety, bleeding.
Exactly. Anticoagulants work by stopping your blood from clotting. That prevents strokes, but it also means if you get a cut or have a stomach ulcer or a vessel burst, you bleed, and you bleed a lot more.
So how did the two teams fare when it came to safety?
The researchers tracked fatal or major bleeding. This is the primary safety outcome. And major bleeding isn't just, I nicked myself shaving. We're talking intracranial hemorrhage bleeding in the brain or significant GI bleeds that require a transfusion.
Okay. Lay the numbers on us.
In the rivaroxaban group, there were 10 patients with major bleeding events. That's 1.6%.
And the aspirin group?
4 patients, 0.6%.
Whoa. 10 versus 4, that's more than double.
The hazard ratio was 2.51. Now, I have to be the responsible scientist here and note that the confidence interval was quite wide. It went from 0.79 to 7.95. That implies some statistical nuance. But the raw signal is hard to ignore. You had more than double the number of major bleeding incidents in the group taking the stronger drug.
So let me try to synthesize this. If I'm a patient in this study and I take rivaroxaban, I am getting statistically the same stroke protection as the person taking aspirin, but I'm facing potentially double the risk of a major bleed.
That is a very fair way to summarize the data from this source. It completely shifts the risk-benefit analysis. Usually we accept the bleeding risk of anticoagulants because the stroke risk is so terrifying. But if that stroke risk is already super low because the ablation worked,
then you're just taking on the bleeding risk for no good reason.
Essentially, yes. You're paying the cost of the drug, biologically speaking, without reaping the profit of extra protection. This is what we call the net clinical benefit. And in this case, for these patients, the math just doesn't favor the stronger drug.
So bringing this all together, what's the big picture verdict from the authors of the study?
Their conclusion was very clear and very careful. They stated that for patients with successful catheter ablation, specifically those at least 1 year post-op and who have stroke risk factors, rivaroxaban was not superior to aspirin.
Not superior. In the medical world, that's a polite way of saying aspirin held its own.
It is, and it brings us to a really powerful aha moment about the heart itself.
Yeah, what does this mean for the physiology? Because we started by saying doctors were afraid the heart was still stunned even after the rhythm was fixed.
This study validates the efficacy of the ablation procedure in a profound way. Think about why we prescribe these drugs. In AFib, the atria are quivering, blood pools.
Right, stagnant blood clots.
But this study suggests that if the ablation is truly successful, the quivering stops. The blood pumps normally again. We call this laminar flow.
Laminar flow, that sounds smooth.
It is. It means the blood is moving efficiently through the chambers. And when blood is flowing smoothly, it doesn't want to clot. The patient's risk landscape changed so dramatically that the difference between a potent anticoagulant and simple aspirin just became negligible.
That is fascinating. It's almost like, imagine you're wearing a heavy-duty fire suit because you work in a building that's constantly catching fire.
Okay, I'm with you.
Then, someone comes in, fixes all the wiring, and installs sprinklers. The building is safe. You could keep wearing the fire suit. It's better protection against fire than a t-shirt. But if there's no fire, the suit is just heavy, hot, and uncomfortable.
And to extend that metaphor, the suit might actually cause you to trip and fall. That's the bleeding risk. If the hazard is removed, the protective gear becomes a liability.
This has to be empowering for doctors and patients, right? I mean, being on blood thinners isn't fun. You bruise like a peach. You worry about every cut.
Absolutely. This data gives clinicians a solid foundation to discuss deprescribing.
Deprescribing. I like that word. We don't hear it enough.
We don't. Medicine is very good at starting medications. We are not always great at stopping them. There's a lot of inertia. It feels safer to just keep doing what you're doing. But this study provides the evidence to say, okay, your ablation was a success. It's been a year. We can step you down from this high-risk drug to aspirin.
And save you from the bleeding risks.
And the anxiety and the cost.
But just to play devil's advocate, or maybe just the cautious friend, this only applies if the ablation was successful, right? I want to be really clear for anyone listening.
Crucial point. Do not stop your blood thinners based on this deep dive. The entry ticket to this study was successful catheter ablation at least 1 year earlier. If the AFib comes back or the surgery failed, all bets are off. The risk profile changes right back to the high-risk category.
So you can't just toss your pills because you feel good. You need to know the procedure held.
Correct, and that implies rigorous monitoring. The patients in the study were carefully checked. But for those who are in that successful bucket, this is game-changing news.
It's really a story about challenging the status quo. Just because we've always done it this way, prescribing thinners for life, doesn't mean it's the right way once the data comes in.
That is the essence of evidence-based medicine. We have to be willing to update our protocols when the science shows us a better, safer path. And this Jan 2026 article is a strong nudge in that direction.
It makes you wonder what else we assume is for life that might not be.
It does. It raises an important question about how we define success in medicine.
How so?
Well, often we think of a procedure as fixing a symptom. My heart isn't racing anymore. But if a procedure like ablation actually restores normal physiology to the point where the standard rules for medication no longer apply, that's a whole different level of success.
It's a restoration.
Exactly. And it invites us to wonder, as our procedural techniques improve in cardiology or other fields, what other lifetime medications might become unnecessary? Are we treating the patient of today, or are we treating the memory of their condition from 5 years ago?
That is a thought that will stick with me. We might be medicating ghosts of past diagnoses.
Medicating ghosts. That is a haunting thought, but an accurate one.
It just seems like we're entering an era where we can be more precise. We don't just carpet bomb the risk. We manage it based on the actual current state of the body.
Precision medicine isn't just about genes, it's about timing. It's about matching the therapy to the patient's current reality.
Well, this has been an incredibly enlightening look at this NEJM study. From the David versus Goliath drug battle to the detective work with the MRIs, it's a great example of how science keeps refining what we know.
And how it ultimately aims to make life better and safer for the patient.
Absolutely. If you're listening and you or a loved one has had an ablation, this is definitely something to chat about with your cardiologist. Don't make changes on your own, obviously, but the data is there for a conversation.
The data is definitely there.
Thanks for diving deep with us today. It's always wild to see how a few charts and p-values can change the way we think about living with a condition.
It's the power of research. Less medication, more life. That's really the goal.
Couldn't have said it better. Until next time, keep asking questions and stay curious.